Good morning, everyone. It is Tuesday, January 11th, and welcome into the Morning Medical Update. Thank you for joining us right here on Facebook and YouTube. We know emergency departments are packed right now due to COVID cases. You combine that with the usual winter weather emergencies like falling on ice, heart attacks, car accidents, you name it. It can be a recipe for disaster. What do you do when winter weather comes, and how do you know when to go to the emergency department? That is going to be our focus today because we are trying to alleviate that surge right now. So make sure you get your questions sent in to us on YouTube and Facebook, and also email them to the Medical News Network. You can find links to those right there on your screen. But first, we want to check our COVID count this morning. Dr. Dana Hawkinson joins us. Good morning.
Yeah. Hi.
Hi.
Numbers today, 119 active infections with 23 in the ICU. A good proportion of those on the ventilator, 16 are on the ventilator. We still have 45 in that recovery period. So we have a total of 164 active patients. Of those active infections, 13 are fully vaccinated. Unfortunately, we did have 2 deaths over the last 24 hours as well. A total of 15 deaths so far attributed to COVID-19 in January.
And do we know if those deaths are unvaccinated? I know I'm just asking the question because I know the public's going to want to know. Do we know that information?
No.
No.
I don't know.
Okay. All right. We will get to reporter questions. Do we have any on the line right now? Okay, I do have one, though, from Fox 4 this morning from Cara. Question is, and Dr. Hawkinson, jump in, and Gail Schutz, I'm going to introduce you here in just a moment, so you can jump in on this as well. But given that we are approaching record hospitalizations across the nation and in Missouri, how much longer do you think the medical system can hold out? Are we on the verge of a collapse? Dr. Hawkinson, I'm just going to start with you and let you take that question.
Yeah, I think there's so many answers or complexities to this. I'll certainly let Gail give the final word. You know, I don't know that we're on the brink of collapse. I think certainly we have questions when we talk about medical care. Who can staff the beds? Do we have the nurses, the respiratory therapists to be in working so they can give that direct care to patients? We know that certainly a reduction in the time you have to be isolated will help our workforce that is home. That will help that. We also know that supply chain is another big component of that. Right now, we are not short on any of those really vital medicines and drugs that you need, either when you're here in the hospital on the regular floors or in the ICUs, but that is one thing we are always keeping an eye on. We know supply chains for many different industries are short-staffed right now, and so it's just hard getting those supplies to us. So, you know, there always is that chance. We always have to be concerned and weary of that. We know that we have had to cut back on some of our surgeries that are not emergent or are urgent to do. So we've done that recently. Dr. Stites has commented on that as well, and I'll just kind of leave that and let Gail answer any of the others and bring up any of those other specifics.
Gail, good morning to you. She's the Assistant Chief Nursing Officer for inpatient and emergency services here at the health system. We're so glad that she is joining us to talk all about this. So a collapse, that's a big word to use when we're talking about something that we all rely on and just assume is going to be there and stable. How do you see it?
Yeah, I don't think we're on the verge of collapse. I think we're stretched, and I think the system is definitely in a place that we haven't been before, but we're being very flexible and teams are working together. And like Dr. Hawkinson said, we've reduced some surgical volume to try and control the volume of the hospital so that we do have the staff and the supplies and all the things that we need to take care of patients. But it is undoubtedly a very challenging time. We're working together with all of our teams, and by all of them, I mean every single person in the health system, to pitch in and help out and make sure our patients are getting great care. So I like to avoid things like collapse and those catastrophic type words, because we really are working as a team and getting it done and pulling those levers to decrease volume where we can. And we can do more of that if we have to. Those are very, very challenging decisions and very, very painful. No one thinks their surgery is elective. People plan around those sometimes for months, most of the time for months. And So those aren't decisions we take lightly, but they are options on the table
Sure.
if the pandemic continues to surge like this.
I don't know. That's your job daily, is to be working through those
All-
decisions.
every minute
every
of
day,
every day,
all
yes.
day. I know. All right. So we're going to help the public understand how they can help, which is to help know when to go to the emergency room, when not to, and maybe how to just avoid it at all and stay safe. So we know that an estimated 1 million people slip and fall every year nationwide due to ice and snow. So between snow, ice, frostbite, emergency departments are swamped during and after winter storms here in the metro. So taking a look at these national numbers may help to explain why. Over 195,000 people are treated in the ER after a fall on the ice. About 28,000 suffer injuries from just shoveling snow and frostbite cases. All these cases vary from year to year, but now we are in a COVID surge, so you can only imagine. Wait times inside emergency rooms are at an all-time high, and today we are going to do our best to keep you out of there. Our guest this morning, again, Gail Schutz, the Assistant Chief Nursing Officer for Inpatient and Emergency Services here at the health system. And also joining us is emergency physician here at the health system, Dr. Ryan Jacobson. He is also EMS physician advisor and medical director of Johnson County EMS. So thank you both for being here. Good morning, Dr. Jacobson. How are you?
Thank you. Doing well.
Good to have you. Lots to talk to you about, lots of questions for you. But Gail, I'm gonna go back to you first, just in general. How has this surge been impacting emergency rooms from where you see it? Kind of paint a picture of what it's looking like inside there.
Yeah, just to give you a quick look, this morning we're holding 20 patients in our emergency department waiting for inpatient hospital beds. So
What would that normally look like? Compare it.
We would want that to normally be 0. As soon as you get admitted to the hospital and you're ready to go to an inpatient floor, we like to get patients moved up to their bed and into their next level of care. So 20 patients holding is a significant amount of patients waiting for beds, and it's a combination of what we're going to talk about along with slips and falls and the winter weather. But winter weather also brings on a lot of viral illnesses, and it's just a busy time in the emergency department. So also with COVID being another viral illness that's just running rampant, that is just layered on top of an already busy season in our emergency department.
So do you have big concerns, some concerns when it comes to now? I mean, today probably isn't a very good example of our winter weather that we see here in Kansas City, but we know it's coming.
Yes, I think big concerns. It's a day-to-day, minute-by-minute challenge to make sure that our patients are getting the care that they need with the staff that we have. So with COVID, of course, we have staff out, and so less staff to take care of more patients is not a recipe for great days or easy days. So we're just trying to take it, really minute by minute. We'll get 15 of those patients got placed already this morning on the floor. So we're just constantly moving and trying to get the patients where they need to be. But it's challenging for sure.
So staff is out. How is staff doing? How are they managing this surge? You talk to them, you see them face to face every day. What's their world like right now?
Yeah, it's really hard for the staff. I think we're more than 2 years into this, and I don't think anyone envisioned this. And it's like running a race and running a marathon when maybe you thought it was going to be a sprint. Those are two very different training tactics. And so our teams are just tired. If I were to sum it up, everyone's pitching in, working together, trying to provide the best care that they can to patients, but day after day after day, that gets very tiring.
So new challenges this time from last year, but are there similarities, differences? It feels like.
Yeah, I think the volume is the difference, and also the sudden rise. If you really look back at the data, and Dr. Hawkinson can chime in on this, literally after Christmas, the number of cases just went like this. And then a number of staff out sick also went like this. We haven't really experienced that sharp of an increase during this pandemic. And so we were able to ramp up and plan a little better than something that just almost seemed like a switch was flipped. And suddenly we have all of these patients and we have all of the staff out sick. And so that was different and a little bit unexpected.
Dr. Jacobson, I want to bring you in this morning. How is this current surge affecting EMS crews? Well, let's just talk about the crews, then we'll talk about the patients. But how are crews managing all of this?
It's incredibly challenging. We have seen an increase in our EMS call volumes as well since the holidays. The struggle we have with EMS is we went into this with a historic shortage of EMS providers in the workforce pre-pandemic. We have had a shortage of EMS providers, EMTs, paramedics for a while now, and we don't really have a good quick solution to the lack of providers to start with. So we started understaffed. Now you can imagine staffing issues with the pandemic. It's really complicated things. For instance, in Colorado, a couple of days ago, their public health department activated crisis standards of care for their EMS, their pre-hospital folks, because of the staffing shortages and a lack of available staff and ambulances. Austin Travis County EMS in Texas, which is a very large, well-respected EMS agency, has 20% of its paramedics and EMTs out due to COVID. So we're really trying as an industry in EMS to manage the workforce shortage along with the rise in call volume, and it's super challenging. The crews are really struggling right now with the increased call volume and the lack of staffing.
Well, first of all, thank you for all you all are doing across our community. And I know you carry that burden on your shoulders and try to keep that away from the patients. How are patients doing? What kind of effect is this having on them? I know you're trying to keep that effect away from them, but it's hard to.
Well, I will tell you, we have not done this previously in our EMS system here in Johnson County. We've had discussions, and including this morning, there have been emails going out for the last few days. We've been actively discussing the option of a 911 response to a patient and us telling them that we don't think they need to go to the hospital. Now, that's a very provocative thing to institute. That is not the typical norm for EMS providers to provide a medical screening exam like an emergency department would and say that you're clear and you're okay to stay at home. Typically, we offer and recommend transport to the emergency department to get evaluated by a higher level of care. But because of staffing, because of the increased call volume, we haven't made the decision yet, but we're actually working towards a potential of basically showing up to someone's house, doing an assessment, and if they meet some low risk criteria in the appropriate age range, if they have a viral illness, that their oxygen saturations are okay, their work or breathing's okay, the comorbidities are minimal, and they have access to phone and things of that nature, we may recommend that they can stay home safely. And that is a very abnormal position for typical 911 EMS to be put in. So we're trying to keep ambulances available for the true emergencies, traumatic injuries, car accidents, life-threatening things, and trying to offload the EDs of unnecessary mild illness. So we're working on trying to do those things, but those are unprecedented in our region for certain, and that's just not normal behavior for us.
Yeah, Dr. Jacobson, my next question was what type of critical decisions that you're making right now to help the ERs? And you just answered the question. So I hear you saying that, the first line would be to talk to someone over the phone. If I call and say, one of my parents or a spouse is having symptoms, you would help talk through that and make sure, or send someone and maybe not have to have them transported to free up ambulance services. But how do we know then? So a lot of people maybe don't call 911, but maybe they just take themselves to the ER. We've been known to do that. It's late at night. Maybe you're feeling a pain. And again, I always say the ER is that place that we just think the doors are always open and you can walk right through and get taken care of. And I know you're trying to do that, but that's not always the case. So how do we know when to get in our car and come down? Or should we be making a phone call to 911 and have you kind of work through that over the phone?
Well, we never want to discourage someone from calling 911 if they feel they're having an emergency. There are a number of good reasons to call 911, and those are you have a lot of comorbidities, you're having trouble breathing, you're having chest pain, you've got some sort of bleeding, the person calling says that you have altered mental status, you're confused, not acting appropriately. There are very good reasons to call 911, and we are glad to respond. However, trying to encourage people to utilize 911 and emergency department resources effectively is really a good message to share to the community, because that's one thing the community can do right now to help offload the EDs and to help offload EMS services from unnecessary 911 calls is to talk to your primary care doctor if you've got access to one, utilize urgent cares. Also, if you don't go to the emergency department just for testing. If you're asymptomatic or get exposed, when we work in the emergency department, we see a number of patients every day that come in that had an exposure who are otherwise well and just want to test, but they're using the emergency department for that. And so we want to make sure people understand the nature and the busyness of the EDs around the entire region right now. We are full to the max, and it's not just one hospital, it's all the hospitals. And it's really hard to take care of people with illnesses that are, basically asymptomatic or very mild that can be taken care of at home.
What about quick care? Are they seeing an influx? Are they getting kind of that runoff? Should we still be utilizing quick care?
I don't know what the volumes are there, but I mean, anything that offloads the emergency department, which we really want to maintain that critical infrastructure for life-threatening and time-critical diagnoses like heart attack, stroke, and trauma. And so anything that offloads the emergency department or the 911 system is a good opportunity to do that. And that's something that the community can help us out with.
Okay, something else they can help do is just be safe this time of year so that they're not tripping, falling, getting in accidents that maybe could have been prevented. We're going to talk a little bit more about that, but I want to get to some community questions from our guests. And Dr. Hawkinson, I do have many for you today, so get ready. But question from Ashley, and Gail, I'll let you just kind of give some insight on this. Is it true that certain KC hospitals are allowing COVID positive staff to come back to work if their symptoms are not bad? What do we make of this? And maybe you could just help us understand what that means, because I know those guidelines have changed as far as going back to work. What can you let us know about that?
Yeah, sure. I don't know what all the other hospitals are doing, but I can tell you what we're doing here. And with a lot of discussion and critical evaluation of the science, we have decided to allow staff to return to work after they've been COVID positive if their symptoms are resolving and they have no fever or have taken fever reducing substances within 24 hours. So they're relatively well when they come back to work. They may have a lingering symptom, but it's an improved symptom. And so we don't feel like we're returning people to work with COVID. We feel like we're returning people to work that have recovered from COVID and are no longer contagious or at risk of passing it on to other coworkers or patients.
So Dennis wants to know, he has a pulmonary appointment on Friday. Important, that's important. Should I reschedule because of the COVID increase?
I think you should work with your physician to decide whether or not it's important for you to have that appointment. I think it's really critical that patients are communicating with their medical teams. We will reach out to you if we feel like you have an appointment that could be delayed, but I want to caution people against delaying their health care.
Yeah, we don't want to create a new problem.
Exactly. They'll wind up in the emergency department and spend a good amount of time there getting evaluated. So better to go to your pulmonary appointment.
Yeah, all preventative. That's the key,
I
right?
think it's a question of, why are you asking to delay? Are you having symptoms, or are you just concerned about the safety of going to that clinics? Again, we have touted and reinforced how safe our clinics and hospitals are. They are some of the safest places in the cities because of the PPE that we're using and the public health guidance that we are using with masking of all people, eye protection, and those things.
Jenny has a question. Dr. Jacobson, what has been some of the longest wait times you've seen? And Gail, I'll have you jump in as well. But tell people what you've described as wall time. When you bring a patient in and they have to wait there to be seen, kind of describe to us what that looks like and can feel like on the patient end.
Yeah, EMS wall time is a national problem that has also been an issue here in the region for some time, but it's really been exacerbated by the COVID pandemic. Since the summer Delta surge last summer, honestly, is when it really got to a boiling point, but now it's really happening again. All the emergency departments in our region are very full, and that tends to be their waiting rooms are very full. So when an ambulance provider contacts the ED via radio and says, we're bringing you XYZ patient, the response we get on the radio from time to time is, well, that patient's going to have to sit in the waiting room, or that patient's going to, you're going to have to wait with the patient in the ED on your ambulance cot until we can find a bed and discharge somebody. Now, remember, the ambulance's primary mission is to take care of 911 calls in the community. So when they're in the emergency department, sitting on the wall with their patient on the ambulance cot, waiting for an ER bed to open up, that takes an ambulance out of commission for the community to respond to a 911 call, and things like cardiac arrest, which are very time sensitive. So we do see an increase in EMS wall times. We have had a number of, we've had up to 50 minutes of sitting on the wall in a hospital waiting for a bed to open where the ambulance couldn't offload the patient to the bed. So it's a terrible thing. It's not ideal. We don't like it. It's certainly less than our optimal way we operate in the EMS system here. But all the hospitals are kind of in the same boat now. We really have huge problems trying to get a patient to a hospital that can immediately take care of the need of that patient, depending on the criticality of them.
Gail, if I walk into the health system's ER, what worst case scenario? How long might I wait?
Oh gosh.
I mean, you're always prepared to wait when you walk in the ER if you've got something that can
Absolutely.
wait. But
Yeah, and I think that's the key in what we're talking about here today is if you have a critical illness, if you have trouble breathing, if you're having a heart attack, you're going to not wait. You're going to be seen immediately. Within a few minutes of arriving at the emergency department, you will be triaged. So a nurse will talk to you about your symptoms and what's going on with you and make that decision about whether or not you need to be seen immediately or you can wait. And so if you come to the emergency room with a sore throat, you may wait a lot of hours. It could be 2, 3, 4, 5 hours waiting. It just depends on how many of those critical patients are coming in. It depends on the time of day. It depends on the day of week. I mean, there are a lot of factors in there, but it is not an efficient process for patients to come to the emergency room for non-emergent care.
where other
They're
sick
just-
people are as well.
Right, there's
Stay
other
home.
sick people, and you will wait. There's nearly no time of day that you're not going to wait if you have a sprained ankle or a sore throat or something like that. So seek medical care at those other, we have an abundance of places where you can go to get care, work with your primary care physician and figure out the best level of care that could keep you out of the emergency room and avoid that wait, because it's really not a pleasant experience for anyone to wait for a long time.
While you're sick, right?
Yeah.
I'd rather be cozy in bed. Okay, so we have a very loyal viewer, Dr. Hawkinson.
Yeah.
He's in Australia, and it's 1 a.m. his
Oh,
time.
wow.
So I have got to get to his question for sure. He may
Yeah.
need to get to sleep. Have we? Could you comment a little bit on just wearing glasses as protection in public? Just due to Omicron, a lot of people think because it's easier to get that maybe
Yeah.
with glasses add that extra layer. And I don't know what kind of glasses he's talking about, but any sort of protective eye gear, would that
Yeah,
help?
and I had this question from a physician here recently. So in the healthcare setting, it is recommended that you use eye protection. And eye protection is not your typical glasses, but it is protection or glasses that have top and side areas to help block. You can kind of see that here. It's frustrating for some of our physicians that do wear glasses because they need additional eye protection, or it's that full face mask. Again, eye protection along with the mask. In the public, it really hasn't been endorsed or recommended by the CDC, but certainly you can. Now, there also has been some data long ago about is there a possibility that just typical glasses or sunglasses may help protect and reduce the chance of getting some of those viral particles into your eye. That is certainly a possibility, but for the general public, there is no real recommendation on using eye protection, but you can certainly do that. That will be one more thing to help reduce your risk. Again, in all of these risk mitigation strategies, we're talking about not just one thing, but a combination of those things to reduce your risk. But certainly here in the healthcare system, we do have specific visors for use, or people also can bring in their own. You know, Dr. Stites has talked about how he got his on Amazon. I got mine from a colleague who got it at Lowe's or Ace Hardware or something like that. So there are a variety of options there to use. You certainly are welcome to do that when out in public. That will be one more step to help reduce your risk.
Doc Hawk, Rhonda also is asking if you could just comment on cloth masks. Unfortunately, she says she's the
Yeah.
only person in her workplace
Yeah.
wearing a mask. So should she be doubling up? Since she's the
Yeah.
only one, should she go to the next step? What?
So this has taken a lot of hits and debate lately. Again, right now the CDC, their guidance is more important than the mask itself, is the fit of the mask. We do know that there are differences in filtration and blocking between cloth masks, and when we say cloth masks, when we're talking about masking, we are talking about those 2 to 3 layer cloth masks, not those thin 1 layer masks such as gaiters or something of that nature. But you have to make sure it is 2 or 3 layers. We know that there are differences in filtration, the ability to block particles either expressing into the environment or if you're inhaling. Certainly those cloth masks, those 2 to 3 layers, would have less of an ability than the surgical masks, but also those would be less than the N95s. We know the CDC is reviewing all of the data right now, possibly going to be making an upgrade to data about using, especially in the healthcare setting, we do use N95 masks when caring for COVID patients, but again, those N95 masks are fit tested as well, so there is that there. I also saw the article today in the Washington Post that said that maybe 60% or more of the KN95 masks that you're able to get in the United States are counterfeit. Not exactly sure what that means, but again, anytime you're buying in the store, you're unsure of the vetting and validation process of those masks. So the answer is, right now the CDC recommendation is to use that 2 to 3 layer cloth mask, or a surgical mask, or an N95 or KN95 mask. We do understand the differences in filtration, but the important part of that is the ability to have that snug fit around the tops and sides of the mask as well. Certainly if you would like to try and get surgical masks or N95 or KN95, that is reasonable to do. But if you're doing those other mitigation strategies, that will help as well. And just saw an article on emerging infectious diseases, which is another CDC publication that did show that people who were wearing masks in exposed persons, when both of those people are wearing masks, that also does help cut down on the overall infection rate of that other person as well. So really right now any mask is okay. Just be careful if you do go buy some of those surgical masks at the hardware store, at the pharmacy, at the grocery store. They may not be validated and vetted and have the same protection ability as the surgical mask that we do use in the hospital. So it is a long, convoluted answer, but right now there is no change in the mask guidance from the CDC.
Well, thanks for the long answer, because we do get a lot of questions right now about masking. Okay, so take a deep breath on this next question.
Yeah.
Okay. Maggie wants to know, what happened to the vaccines working? If they worked, why do we see a rise in the numbers?
Yeah. Well, they do work, actually. So the vaccines were never made to block infection. That was actually an interesting point early in those studies. And we still see that it helps to block infection early after that vaccine period, whether it's after the second dose or after that booster dose, especially within that first 3 months or so when your antibody levels are so high. But then antibody levels do contract or decrease. That is what happens in the natural vaccine or infection process. But what we are seeing is that the vaccines work. So the vaccines were never created to stop infection. What they were created for was to reduce your risk of hospitalization, severe disease, and death, and they continue to do that. And they have continued to do that throughout all the variants that we have seen so far. Now, there are details in there about time out from vaccine. Are you at higher risk, meaning do you have an age above 60 or 65? Do you have other immune compromising conditions? Do you have other comorbid conditions such as chronic kidney disease, heart disease, lung disease, diabetes, obesity? Those things all contribute, but for the most part, the immense benefit that we have seen from vaccines for preventing hospitalization, severe disease, and death in all groups of people is greater. And we do see that cumulatively through the United States, and even here in our region and even here at our hospital, we see that the vast majority of the people that are hospitalized are unvaccinated. And so I think it is important to note that the vaccine was never created to stop infection. There's only one vaccine that really stops infection, and that is the HPV vaccine, which if you are eligible or your children or people you know are eligible, please go get that. But that is the only sterilizing vaccine that we really have. All of the other vaccines don't prevent infection. What they do is prevent disease, and that serious disease.
Thank you for that. Isaac wants to know, I've read some stories about people flooding emergency departments in search of COVID tests because they're in such short supply. Is that something we're seeing, Gail?
Absolutely. And Dr. Jacobson alluded to it, that patients come to the emergency department to get tested. Unless you're having symptoms, that is not the right approach.
So Should you not I think if we back up a year ago, people were thinking, I have COVID, I should go to the emergency room and get care. Is that no longer the case?
If you're
vaccinated?
Right. If you're not having symptoms or significant symptoms, you do not need to come to the emergency room just to prove that you have COVID or get a test. And I know testing is challenging right now, so we have actually seen an uptick in the midst of all of the other upticks in emergency care, in people just coming to get a test. And so if you don't need medical care, it's really not the appropriate place to come and just get tested. There are other options around the city for getting tested. It may take a day or two, but if you're not sick, I would encourage you to isolate and assume you have COVID and then get into a testing site or try to find an at-home test. Again, those are very difficult to find right now, but seeking emergency care is not needed unless you actually have significant symptoms that you need to be seen.
Dr. Jacobson, what are you seeing or hearing?
Yeah, I mean, most of the folks that we see that are discharged from the ED with diagnosis of COVID or concern for COVID are the young and healthy. And we see a lot of folks that are coming in who, teenagers, 20s, 30s, 40-year-olds, who are healthy with no comorbidities, but want to know if they have COVID. They may have a fever, body aches, sore throat, a cough. But at the end of the day, if you're not really having shortness of breath, you're having trouble catching your breath, you're passing out, can't stay hydrated, intractable, unable to stop vomiting or diarrhea, or some reason that you need to come to the hospital and get some resuscitation or some therapy, really our treatment is symptomatic. And we discharge those folks home with a diagnosis and to isolate and what things to look for when they should come back. And, you can get the disposable pulse oximeters, Amazon, not the disposable, but the little battery operated finger pulse oximeters. People use those for some peace of mind if they're having a cough and, looking at their oxygen saturations and things. But there's a lot of stuff at home that's just symptom control. And that's what we're providing. We're not providing anything. If you don't have any comorbidities and you're well appearing and, a fever in itself is not incredibly dangerous and it makes you feel poorly, but a fever and body ache, sore throat, all that stuff is part of the viral illness. And those are the folks that we're sending home, and they could avoid ED visits for mild illness like that or asymptomatic illness.
So Jim has a question. Just if Omicron has been said to be less severe with the symptoms, why are we seeing such a surge of people? Why are they coming I
think people are nervous.
Okay.
I think they worry that they could get sick very quickly. It's a newer variant. We're still learning about it, but I think people are fearful. And then also the inability to get tested, I think, is causing people to seek medical care, to get tested. And again, I think people just want to get checked out. You hear you have COVID and that it's scary.
Well, and if you're unvaccinated too, you don't know where it's headed. So.
And lots of people do have comorbidities, regardless of your age. And so I think people want to come and get checked out, but it's just, it's flooding our emergency department with people that probably don't need to be getting checked out or could see their physician.
Dr. Hawkinson, you had a follow-up to a previous question.
I want to answer that first question about Omicron. I've gone on the record, and certainly Dr. Stites and I don't necessarily see eye to eye to that. I think the narrative and the story that's been portrayed that Omicron is less severe, I think, is wrong. I think all of the variants that we have seen are essentially the same. They fall under the same umbrella. Now, Delta may increase your risk of hospitalization. We have seen that, or severity. But again, if you remember, they say Omicron is less severe than Delta. So I think overall, the viruses, the properties are the same. It's difficult to say that Omicron is less severe knowing that mutations and changes in Omicron are present in Delta, Alpha, and some of the other variants as well. Those things that help reduce your immune response to the virus. I think it's a lot of also just immunity, whether you've had COVID-19 in the past and maybe have some immunity. Of course, vaccination helps as well, but I think just saying that Omicron is less severe, I don't know other proof that we have, either basic science or clinical proof to prove that. So I think it's a misnomer, and I think that does then tell people that it's maybe no worse than a cold, which it is. And I think the thing to do to protect against this that we have shown is vaccination. Vaccination does protect, especially after that boost dose, after 5 or 6 months after your full vaccination. It does protect against severe hospitalization and death. The other benefits of vaccination that we have also seen, the data continue to support the fact that it does reduce your chance of getting long COVID. We also, a new publication in MMWR also does show that it helps reduce especially those children's risk of getting that multi-system inflammatory disease. So again, it's not necessarily about blocking infection as it is helping reduce your chance of getting some of those other complications of disease.
So on that topic, Faith wants to know, do we have a protocol on what we tell patients on how to heal or better take care of themselves at home if they're fighting COVID at home to keep them away from the ERs or having to come to the hospital? Dr. Hawkinson, I'll let you start. What should people at home with mild symptoms do to keep them from progressing?
You know, everything that's old is new again. We did go through this early on in the pandemic, and we were very blunt about saying and transparent. The vast majority of people will not need to come to the hospital or seek medical care. That still holds true. Unfortunately, the numbers of cases are so high that even those smaller percentages make for whole numbers that are greater. So it continues to be self-care at home, managing those symptoms, conservative measures. So obviously rest, nutrition, hydration, drinking plenty of fluids. If you have fevers or aches, you can take Tylenol and ibuprofen. And really your body, you are going to know your body the best and when it's time to seek medical care. If you are having worsening or progression of symptoms, worsening cough or shortness of breath or chest pain, things of that nature, you are going to know when to come to the hospital. But again, it still holds true as it did early in the pandemic. The vast majority of people will not need to seek medical care. But when you have so many people infected, even that smaller percentage of 15 to 20% who need to seek medical care, that is going to be a high overall number.
So Dr. Jacobson, Gail, weigh in on this. What can we do, the public, to prevent going to the emergency room? Again, today's going to be a pretty nice day today, but we know that the winter weather is coming. What can we do just to be thoughtful and thinking about ways to minimize slips, falls, not getting on the icy roads if not necessary, working from home when you can? Gail, I'll let you start. What advice do you have for us?
Yeah, I think it's just the basics, right? Keep yourself safe, take precautions, wear your seatbelt, do all of those risk mitigation things that you can do. I think people are probably not aware that slips and falls on the ice can be pretty detrimental. Thousands of people actually die each year from slipping and falling on the ice. One of my ED colleagues shared that it's anywhere from a bruised ego to a significant head injury from a fall on the ice. So, you know, I think we want to make sure the bruised ego just stays at home and manages their slip and fall. And then, of course, if they need emergency care, that's what we're here for. And people don't plan accidents, and people think they're preventing accidents. But, you know, be safe. And I think wearing your mask when you're out in public and using those infection control pillars will keep people safe from not just COVID, but all kinds of viral illnesses that bring people into the emergency department. So above being safe on the ice and wearing your seatbelt and doing all those things, just be safe with your masking and your distancing, and that will help us.
And again, yeah, like exactly, that'll help you. We are not discouraging anyone from picking up the phone and calling 911 for help, and we are not asking people not to come to the ER when you need us. We're just trying to help you understand when is the best time to go and how to know when to go. Dr. Jacobson, what can we do to help your folks out, your teams out?
Yeah, if you were ever going to adopt a risk-averse lifestyle, this would be a great time to begin your risk aversion. If you're not, we don't wear helmets, use seat belts, walk cautiously on ice. I think it's just, the things that we always took for granted, routine injuries that, I cut my hand, I have a laceration, I sprained my ankle bad, I can't walk, and you normally go to the ED. Those type of minor injuries and bumps and bruises symptoms can ruin your entire day because you may be in the ED for many hours. So there's some stuff that you have to go to the ED for and you can't avoid. And it's just, I think, always asking for patience from the patients themselves and the public, and saying that, our 911 workers, our emergency staff and the hospitals are overworked. We're facing burnout, I think, is a huge issue in healthcare right now. And be kind and gracious and, understand that we're trying so hard to get to everybody in time and to make people comfortable as they can while they're sitting in the emergency department. And the restrictions on family and all that stuff, those are just things that are a part of our reality now. And so trying to get people to understand that we are also not happy with the situation as people who are providing the care. So if we can just, really encourage people to kind of give people a wide berth a little bit and understand that this is a hard time for all of us. And I think, again, trying to stay out for preventable things like minor slips and falls, trauma, I think is a very good idea if we could do that now.
All right, good advice. Dr. Hawkinson, Lesko has a question specifically for you. Can you comment on the potential natural immunity level in the community at this point?
Yeah. I can't comment on what it would be. We know that people have been infected a couple of times at least. We have seen that. We hear stories about that. I don't have a good answer for you as far as proportions or fully vaccinated. We know that in the United States, I think it's about 62% maybe that are either fully vaccinated or have received one dose. Overall, I think the proportions are low. Natural immunity, as far as what we are seeing, is that it really doesn't hold up as far as neutralizing antibodies and the ability to protect against disease, as does, say, someone who has been vaccinated. Also, we know that if you've been infected before and not been vaccinated, there is differences and there is heterogeneity in what will happen with the second time. Where some people may do much better and have no symptoms. Some people may have the same exact disease, and other people may have more severe disease. Also, what we know is that if you have been infected and you do have that vaccine dose, that you have more of a hybrid and probably the best immunity that you have developed with your immune system. But overall, as far as rates, I can't necessarily comment. I think it does help. But really, the bulk of the data and information would show that people can have different outcomes even if they have been infected before and done well. They can have the same, worse, or better disease process than they did the first time.
Great questions, and we're going to try to get to some of these tomorrow, but I'm going to give the last one to Gina. Dr. Hawkinson, if a friend of hers had a positive over-the-counter test, but a negative PCR test, should she avoid them, and for how long, if so?
Yeah, I mean, we do know that some of the tests have given false positives. We've seen those in the media. Certainly you can Google and see if that test in particular has been one of those that may have had a bulk of false positives. But I think if somebody is symptomatic or if they know they have been exposed to somebody with COVID-19 and they do have a positive at-home test, I would consider that a positive, and kind of, if you can, try to avoid or do those mitigation strategies. I think that would be the smartest thing to do. It's hard to talk always on some of these discordant results because there are some details in there that we just don't know about.
So could that just be a random positive, or should they get retested?
Again, I think if you have been exposed to somebody who you know has COVID-19 or you are symptomatic, I think you actually should treat that out of an abundance of caution as a true positive.
Makes sense. All right, let's get to our final thoughts today. Such a great conversation. Glad you were with us. Dr. Jacobson, I'm going to let you get us started.
Yeah, I think the one thing that the community can help with just in this time of, soaring cases and burden on the health system is to help us make sure that, 911 and emergency department services are being used appropriately. And we always encourage people to call 911 if you're having trouble breathing, if you're having life-threatening, severe problems, or you can't make it to the emergency department. Of course, we want you to call. But at the same time, healthy folks, mild illness, exposures, those types of things, we encourage alternative means. Seek out your primary care doctor, urgent care, other alternative care sites, and use friends and family, things like that to get to places to help maintain the 911 fleet in the region to respond to emergencies. So I think that's probably the biggest thing, is to just avoid unnecessary kind of low acuity, mild things that could be taken care of outside the emergency department without an ambulance.
Gail Schutz, thanks for sitting here with me today. Appreciate it.
Thanks for having me.
Final thoughts. What do you want us to know?
I just want the public to know that we are here for them. Our emergency room is open 24/7, and you will get amazing care when you come. We want to make sure that people that are having life-threatening conditions or severe illness or injury are coming to the emergency room. I think people have to decide that for themselves, but don't spend too long deciding you're going through your list of symptoms. If you really are sick or you're really having an emergency room, please call 911. Please come to our emergency department. Just use really good judgment, because it is a really stressful time right now, and you're going to spend some time waiting if you're not seriously ill or injured. But we are here for you 24/7, and we will do our very best to take amazing care of you, and just want to encourage people to be safe and know that we're here for them in the event that they need us.
So when I talk to your colleagues, I know you guys are bearing the brunt, and I always hear you in the end say, we always figure it out. It's not
We do.
easy, and you
Yep.
bear that load on your shoulders, I know. And Dr. Jacobson, you, all of our frontline staff, our EMS workers, so we appreciate you always figuring it out for all of us, and appreciate all the work you're doing. Dr. Hawkinson?
Yeah, on the subject of vaccination, we know that in the U.S., looking at that, there is 74% of the population has received at least one dose. 62% are fully vaccinated, so that's really just those 2 doses of the mRNA vaccine, and then 36% have had that booster dose. So we know there is good early data out of Israel showing that those booster doses do help reduce hospitalization and death, especially in those people who are higher risk, for example, those over 65. As far as those people who have just had natural infection, I think it is much better if you had natural infection to get at a minimum 1 dose of the vaccine, because what that does, just as the booster dose does, is if it is far out from that infection, you are then giving a boost to that immune system that has already been activated from that first infection. You are boosting those T cells and B cells to develop more, have a better response. So I think that is very important as well.
Thanks so much, Doc Hawk. All right, thanks to you all for being with us today. You can catch our show anytime by logging on to our Facebook or YouTube channels. You can also watch our previous shows that you may have missed, or you can search a topic that may be affecting you right now. Coming up tomorrow on Open Mics with Dr. Stites, will predictions that Omicron will peak at the end of the month hold true? What does that mean for us? Will healthcare systems get a much needed break? And could this help with the worker shortage? Join us tomorrow. We'll see you straight at 8. Have a great day.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.